When a patient with rheumatoid arthritis does not respond to the first tumor necrosis factor inhibitor that you try, and you know that it's a primary failure to respond, it's probably time to cut your losses and switch to a drug with another mechanism of action.
If by 12 weeks you have no response at all, then it's time to change. If, on the other hand, by 12 weeks you have a little response, just the beginning of a change in the DAS, etc., then it really makes sense to wait another 8 to 12 weeks before deciding to go to a different mechanism of action. There are now 3 different, essentially, mechanisms of action among the TNFi. There's the antibody, there's the receptor, and there is the certolizumab, which is a pegylated form of the antibody. Each of those is actually a bit different. When you go beyond the TNFi, the principal mechanisms of action are a T-cell specific drug, abatacept, a relatively B-cell specific drug, rituximab, and a drug which is an antibody against interleukin-6 receptor, tocilizumab. The issues that you think about are the differences in mechanisms of action for that particular patient, the differences in kinetics for that patient. For example, some of these drugs have very long half-lives, so they're given infrequently. One of these drugs maybe gets into the joint better than the others. Then you have to consider differences in adverse events. Some of these drugs really have a different spectrum of adverse events, although for any individual patient you can't tell that very well, and patient preferences.
Reporting from the Perspectives in Rheumatic Diseases 2010 seminar, I'm Sally Cubiton for Global Medical News Network.